guys, welcome back to Vital Signs. Today we're talking about the integumentary system. If you're new here, I'm Professor Thomas. I'm here to give you a crash course on all things anatomy and physiology. Let's dive in. The integumentary system is your skin, and your skin is made of layers. The most superficial of those layers is the epidermis. The epidermis is made of even more layers, and we call each of those layers a stratum. We've got a stratum corneum, we've got a stratum lucidum, we've got a stratum germinativum, a lot of layers. What I want you to focus on is that most superficial layer, the stratum corneum, and that deepest layer, the stratum germinativum. The stratum corneum has a lot of keratin in it. Keratin is what gives skin its waterproof quality. If you think about when you take a shower, does the water absorb directly into your skin? No, it bounces off and goes down the drain eventually. The keratin is what gives that skin its waterproof quality. Going deeper, we have the stratum germinativum. Have you ever had a cast on for 6 or 8 weeks? And when you take it off at the end, there's a bunch of dead skin cells in there. We're losing skin cells all the time. And we replace them so we don't run out. Those replacements are coming from that deepest layer of the skin, the stratum germinativum. Within the stratum germinativum, we have melanocytes. These are responsible for producing melanin, which gives skin its pigment. Not to be confused with melatonin that makes you fall asleep. Melanin gives skin its pigment, and how much melanin our melanocytes are producing depends on two things: genetics, your skin color tends to look like your parents' skin color, and UV light exposure. When you go out in the sun for a really long time, for weeks on end, what happens? Your skin color gets darker. This is a defensive mechanism of the skin, producing more and more melanin to protect itself from UV radiation. A key term you want to know about the skin is cyanosis. Cyanosis is a bluish tint to the skin that happens when there's low oxygen being delivered. Deep to the epidermis, and before we even get to the dermis, we've got this junction. And that junction is called the dermal epidermal junction. It's a connection point, works kind of like Velcro, holding the layers together. There are these small bumps called dermal papillae that stabilize this junction. And when the layers get separated, like when you wear a new pair of shoes and it's rubbing on your ankle all day long, you get a blister, that's a separation of the epidermis and the dermis. It fills with this watery fluid. Going down to the dermis, there are two layers here, a papillary layer and a reticular layer. The papillary layer has dermal papillae and dermal ridges. If you look at your fingertips, you can see you have fingerprints, and this is because of the dermal ridges that exist within the dermis. The reason we have fingerprints is to improve our grip for tool use. The reticular layer is the deeper of the two layers of the dermis, and we've got a lot of collagen and elastin here. That'll decrease as we age and therefore contribute to the formation of wrinkles. When the reticular layer is stretched too quickly, like during pregnancy or some kids have really fast growth spurts, we'll see the development of stretch marks. Our proper term for stretch marks is striae. There's a lot going on in the dermis, honestly. You've got sweat and sebaceous glands, you've got hair follicles, muscle fibers, nerve endings, and blood vessels as well. When those blood vessels get malformed, that's when we see a birthmark. 3 birthmarks that I want you to be able to recognize are port wine stain, strawberry hemangioma, and stork bite. Of those birthmarks, a strawberry hemangioma is the one that will fade with age. Below the dermis, we have the hypodermis, also known as the subcutaneous tissue or superficial fascia. It's got 3 names. This isn't technically a part of the skin, but it's like an anchor. It's connecting the epidermis and the dermis to those deeper structures beneath, like muscle and bone. Moving on to skin structures, we've got hair, we've got nails, we've got receptors for sensation. Let's start by talking about hair. Hair grows in these pocket-like follicles in the epidermis. And have you ever noticed how a baby's hair is different from an adult's hair? That's because it is different. We call the soft hair of a newborn lanugo. Hair growth happens within the tube of the hair follicle. Hair-forming cells are on these bumps on the hair follicle called the papilla. Hair has keratin just like the epidermis, but it's a little bit different. It's a stronger form of keratin and it's more cylindrical. The hair root is the part that's hidden in the follicle. The hair shaft is the visible part. Any form of hair loss is referred to as alopecia. It can happen for a lot of different reasons. And there is a muscle we want you to know relating to hair. Have you ever watched a scary movie or had a sudden chill and all the hairs in your body stand on end? Goosebumps? The reason that we can have goosebumps is because of the erector pili muscle. These are little muscles attached to each hair that pull them to stand on end. Nails are produced by epidermal cells at the distal ends of fingers and toes. The visible part is the nail body. The root is hidden under the skin, connected by a cuticle. If you look at your nails and you see there's a little crescent moon-shaped bit at the base or near the cuticle, we call that the lanula. Your nail bed can change color depending on how much blood flow it is getting. Two pathologies I want you to know here are onycholysis. This is the separation of the nail from the bed, and pitting. Pitting is very common in psoriasis patients. It looks like a bunch of little dents on the nail body. Talking about receptors now, we call a lot of the skin receptors corpuscle. For example, you might have a tactile or Meissner corpuscle that is there for a soft, gentle touch. We have lamellar or Pacinian corpuscles that are there to detect pressure. So different receptors for different sensations. We've got nociceptors that are specifically detecting pain, thermoreceptors that are detecting temperature. Talking about glands now, we have sweat glands, which are also called sudoriferous glands, and sebaceous glands that'll produce sebum. With sweat glands, there are two types of sweat glands you'll find across the body: eccrine and apocrine. Eccrine are the most numerous, they're the most widespread. Apocrine stick to the axillary region, which is your armpit, and the genital area. They'll produce different secretions as well. The apocrine sweat glands produce a milkier secretion, and you might be thinking, oh, that's why my armpits stink. No. Sweat on its own does not have a scent. It is the reaction of sweat with bacteria that makes it smell bad. Sebaceous glands produce sebum. Sebum is the oil that keeps your skin lubricated, keeps it from drying out and cracking. And this is going to be heavily influenced by sex hormones. That's why teenagers tend to have oilier skin. They've got this sudden influx of sex hormones that makes those sebaceous glands overactive. And sometimes when we have overactive sebaceous glands, we'll get something called a comedo. A comedo is a blackhead. Or maybe those sebaceous glands will get inflamed. That's acne vulgaris. Taking a step back, talking big picture about the main functions of the skin, protection is a big one. Temperature regulation is another. The skin can release almost 3,000 calories of heat per day. Sensation, excretion. When we say excretion, we're excreting things through sweat. Things like ammonia, urea, uric acid, synthesis of vitamin D, assuming we have UV light exposure. We're getting into pathology now, talking about lesions on the skin. When you have a lesion on your skin, it's either going to be elevated, flat, or depressed. Some examples of elevated lesions would be a papule, which is a small, firm, raised lesion. Any bigger than that would be considered a plaque, which is a larger raised lesion. A vesicle is a blister. If it's filled with pus, we call it a pustule. A crust is a scab, and a wheal is a hive. Our only example of a flat lesion that you would need to know is a macule. That's our scientific word for a freckle. And then for depressed lesions, you want to be familiar with an excoriation, which would be like a scratch. An ulcer would be a crater-like lesion, and a fissure is a deep crack or break. Keep in mind the skin has a really high capacity for repair. Moving on to burns. Burns are classified by degree: first, second, third, fourth. If you've got a first-degree burn, good. That's not as bad as it could be. We're just talking about those upper layers of the epidermis. Once we hit second degree, we're getting into the dermis. A third-degree burn is full destruction of the epidermis and the dermis below it. And a fourth-degree burn means we can see muscle or bone. How we can calculate the percentage of the body that has been burned is using something called the rule of nines. I recommend running through some practice rule of 9 problems, especially if you're preparing for the NCLEX. I'll put one on the screen now. Pause and see if you can figure it out. Okay, let's talk about it. The back of the right arm is 4.5%. Posterior trunk is 18%. Front of the left leg is 9%. Anterior head and neck is 4.5%. Perineum is 1%. If we add it all up, this patient is at 37% of their body that's been burned. Moving on to some skin infections, you want to be familiar with impetigo. This is either a streptococcal or a staphylococcal infection of the skin, highly contagious, more common in babies, infants, young children, because they're touching everything. And it's going to present like these yellowish brown crusty masses around the nose and mouth. You want to be familiar with something called tinnias as well. Tinnias are fungal, different from impetigo. Impetigo is all bacterial. And there's a lot of different fungal problems our skin can have. Have you heard of athlete's foot? That's tinea pedis. Have you heard of jock itch? That's tinea cruris. Have you ever seen someone with a strange circular bulb patch? That's tinea capitis. All of those are fungal infections. Then we have warts. Warts are benign neoplasms, benign tumors, caused by human papillomaviruses. So those are viral in their cause. Boils are staphylococcal infections of hair follicles, so they're bacterial. If we have just one boil, it's a furuncle. If a group of them fuse together, it's a carbuncle. Furuncle is just one uncle. Carbuncle is a group of uncles in a car. That's how I remember it. Lastly, we have scabies, which is an infestation of the human itch mite. It climbs underneath the epidermis, lays its eggs, and this results in a really itchy rash that kind of looks like pimples. Decubitus ulcers are bed sores. Bed sores develop when we have constant pressure on an area of the body, which slows blood flow to that region. If we don't get blood flow to an area, it dies. Scleroderma is a disorder of blood vessels and connective tissue that results in a hardening of the skin. Psoriasis is a chronic inflammatory condition accompanied with scaly plaques. And eczema is a very common inflammatory condition resulting in papules, vesicles, and crusts. It's not a disease on its own, it's usually a symptom of an underlying condition. And there you have it. That is the skin, that is the integumentary system. Thanks for joining me this time on Vital Signs. I'll see you next time.